Hello everybody, my name is Michael Macias. I'm one of the UCSD Ultrasound Fellows. Today we're going to give you a brief introduction to soft tissue and musculoskeletal ultrasound. The reason we talk about this is because MSK and soft tissue complaints actually rank among the top 5 most presenting conditions in the emergency department. From the diabetic with redness to the groin region, to the avid wrestler who popped out his shoulder, to the painful swollen joint. This category is defined by a broad range of diagnoses that you can use ultrasound to assist with. Not only can ultrasound be superior to alternative imaging in some cases, it's much cheaper, less time consuming, and can help you make a definitive diagnosis or at least increase your clinical suspicion for a different clinical diagnosis very rapidly and at the bedside. Even better, as compared to static imaging such as X-ray or CT, ultrasound provides us with dynamic views of what's going on below the skin, whether it's assessing a ligament, performing a reduction of a shoulder, or aspirating a joint. Ultrasound is a real-time aid to assist with your clinical practice. While the entire category of soft tissue and MSK ultrasound is quite broad, in the emergency department, there are very specific questions that we like to answer with this type of ultrasound, and we'll talk about those indications. We'll also focus on core concepts to help you understand the principles of MSK and soft tissue ultrasound, give you a brief overview of sonoanatomy, and then help you develop an approach to common presenting soft tissue and MSK complaints. So when we talk about indications and scope of practice, the main things we're looking at is defining when we should be using ultrasound for MSK and soft tissue complaints. I find ultrasound to be most useful for differentiating abscess versus cellulitis in soft tissue infection. Many providers previously had thought that physical exam was very useful for this specific type of complaint. However, a lot of data is now showing that the physical exam may only be around 75% sensitive. Using ultrasound, that sensitivity increases dramatically. Furthermore, the ultrasound can be used to ensure complete drainage of an abscess, to help differentiate between a joint infection versus a soft tissue infection, and to help identify early signs of necrotizing fasciitis, such as gas or deep fascial fluid. Other indications for MSK and soft tissue ultrasound include evaluation for foreign body, joint aspiration, evaluation of a tendon injury, fracture, as well as shoulder dislocation and reduction conformation. So now let's get into some core concepts. The main probe we'll be using for soft tissue and MSK ultrasound is the linear probe. Most of the structures we'll be looking at are close to the surface, and we'll want to be able to differentiate structures. So we'll want something with high resolution. And we'll also want something with a small footprint so that we're able to get good contact with the surface. So your linear probe will work for the majority of your scans. However, there are a few caveats. For obese patients that require more depth for visualization of target structures, or for a larger field of view, a curvilinear probe may be substituted. Specifically, I find the curvilinear probe more useful for assessing for shoulder dislocation as well as for hip effusions. The next concept I want to talk about is patient positioning. This will really vary significantly based on the body part being examined. However, it is important to make sure that the patient is comfortable and that you're supporting the extremity being examined to avoid unnecessary movement and artifact. If a joint or tendon is involved, positioning should ensure that dynamic examination is possible. For example, when evaluating the knee for a patellar tendon disruption, it's important to have the knee flexed with the hand held under the knee and visually watch the patellar tendon move as the knee is attempted to be extended. This will allow you to visualize if it's a complete tear or a partial tear, as well as to assess for swelling of the tendon. The next thing I want to talk about is orientation. While musculoskeletal ultrasound encompasses a variety of scans, the technique across these various uses remains the same. Whenever a structure is being examined, such as a tendon, this should be done systematically, evaluating the anatomy of interest in 2 orthogonal planes. The reason this is so important is because artifact will often be seen and can be misidentified as pathology. That's why it's always useful to look in 2 planes and be sure that what you're seeing is actually true pathology and not just an artifact, a shadow, or you simply lifting your probe off the skin. You can further confirm if what you're seeing is indeed pathology by comparison to the opposite side. The beauty of musculoskeletal ultrasound is that for most scans, an internal control is always available. When scanning, whether this is for a joint effusion, a potential fracture, or a tendon injury, it's always useful to compare the abnormal side to the normal side of the patient. This will help with easier identification of what is true pathology. For example, here's a case of a 7-year-old presenting with left hip pain and fever. The left and right image are both long axis views of the femoral head and neck. Looking at the left, we notice a significantly larger effusion compared to the right. This was diagnostic, and an ultrasound-guided arthrocentesis confirmed the diagnosis of a septic joint. Dynamic imaging is really what separates ultrasound from other imaging modalities such as X-ray or CT. Often, musculoskeletal and soft tissue examinations will involve evaluation of moving parts, making dynamic imaging quite useful. For example, when evaluating for tendons or muscle injury, passive or active range of motion of the joint of interest may be helpful to better elucidate pathology, such as a partial tear or a complete tear. In the image here, notice that the shoulder is being internally and externally rotated as the rotator cuff is visualized. This view would be useful to evaluate for a partial or complete tear of the rotator cuff. While the majority of soft tissue and MSK injuries are amenable to direct pressure with the ultrasound probe, small parts such as finger tendons and joints are often difficult to assess with direct placement of the ultrasound probe on the skin, given the superficial nature of the structures of interest and even patient discomfort. The water bath will be your best friend here and will allow for excellent visualization of your anatomy as well as less pain for the patient. You may also try a plentiful quantity of gel, however this can get messy. Here's an example of a finger submerged in water. Notice you can see the black anechoic water overlying the finger and be able to evaluate underlying structures of the finger, including the cortex, as well as to evaluate for fluid in the joint and soft tissue swelling. The next concept I want to talk about is anisotropy. This is a key concept to understand in musculoskeletal ultrasound. Anisotropy translates to mean directionally dependent, and is a result of the fibrillar nature of structures such as tendons and nerves, and to a lesser extent muscles. This quality leads to the ultrasound image varying depending on the angle between the structures of interest and the ultrasound beam. This is also known as the angle of incination. For example, when the angle of incination is perpendicular to the tendon appears bright and normal. However, as the angle varies, the tendon can take on a hypoechoic appearance. Do not be fooled by this when evaluating for a tear, as you may just be appreciating this phenomenon. However, if you do notice that a muscle or tendon does not display the property of anisotropy, this can be a sign of underlying muscle or tendon pathology. Here's an example of anisotropy. There's the tendon there. You can see it get bright as the angle of incination is perpendicular, and then dark again as the ultrasound is fanned through. And you can see the operator going back and forth and the tendon changing color. This is a normal tendon, and if you weren't familiar with anisotropy, you can easily mistake it as edema of the tendon and potentially a tear. So now let's briefly move from concepts and start to begin to talk about some sonoanatomy to help you make identifications of structures easy. So we're going to start with the soft tissue anatomy. So the musculoskeletal and soft tissue layers can be divided into superficial and deep portions. The superficial portion consists of the epidermis as well as the subcutaneous tissue. The epidermis will appear as a solid hyperechoic line of varying thickness at the very top of the screen. The subcutaneous tissue is relatively hypoechoic with intermittent lace-like stranding. The deep portion consists of muscles, tendons, ligaments, bones, and joint spaces. Notice the muscular fascia is a hyperechoic line that separates the superficial from the deep portion. Nerves and blood vessels will run through this area, and this will often be the area where nerve blocks are performed. Muscle, on the other hand, will appear hyperechoic relative to the subcutaneous tissue, with striations that run parallel in a particular direction. At the bottom of the image, we appreciate bone, which is a smooth hyperechoic line with posterior shadowing given its strong reflective characteristics. Now let's talk about a joint, specifically the shoulder. Before we get into anatomy, let's talk about positioning and where to place your probe. Notice that when performing ultrasound of the shoulder, the operator is positioned behind the patient with the ultrasound on the other side of the bed. Next, the scapular spine is located by palpation and the ultrasound probe is placed directly on it right at the tip of the acromion. The ultrasound probe can then be slid slightly inferior to the scapular spine and the shoulder joint will pop out. In the image shown, notice the humerus and glenoid are demarcated. Posterior is up, anterior is down. Lateral is to the left of the screen and medial is to the right. What you'll also notice is the round humeral head and the straight glenoid articulate in a normal alignment. Here we can draw a straight line across and see that they both lie along this line. In a dislocation, we'll see displacement of the humeral head either anteriorly, as in the anterior dislocation, or posteriorly towards the skin in a posterior dislocation. And here's an image of an Achilles tendon. Notice on the right of the screen we can see the calcaneus, and just superior to that is the Achilles tendon. It's a long fibrillar-like structure that attaches sharply to the top of the calcaneus. When evaluating a tendon, the tendon needs to be evaluated all the way from its insertion all the way to where it inserts on the muscle. Here you can see the operator moving up and watching the tendon attach to the gastrocnemius. As we discussed earlier, you should always evaluate structures of interest in two orthogonal planes, and you can see here that the operator turns the probe transverse and evaluates the tendon in the short axis all the way back down to its insertion site. And the last structure we want to talk about when evaluating soft tissue and MSK is the nerve. This will often be something we are primarily targeting if we're doing a regional nerve block, or something we'll be wanting to avoid when attempting to place a peripheral IV or perform an incision and drainage. You'll often hear a nerve described as having a honeycomb appearance, and what this is referring to is the anechoic nerve fascicles seen within the nerve and the surrounding hyperechoic perifascical tissue, creating what looks like a honeycomb. Now let's zoom out a little bit and take a look at a nerve within the surrounding tissue. What you'll notice here is the median nerve lying directly in the middle of the screen, and just surrounding it is the muscle fascia between the flexor digitorum superficialis and the flexor digitorum profundus. As discussed earlier, nerves and blood vessels both run along the fascial planes of muscles, and this will be an important concept when understanding the principles of regional anesthesia. Lastly, remember that just like tendons, nerves demonstrate the property of anisotropy, and their echogenicity will vary with the angle of incination. So now let's move on to assessment. First, we're going to talk about a common presenting complaint in the emergency department, the red and painful skin. So it can be very difficult at times to differentiate between a cellulitis and abscess. This is even more important in the IV drug user population, where there's overlying erythema and swelling, and it's tender to touch, and it's really hard to get a good exam. There are some studies that have shown that the physical exam may only be around 75% sensitive. So when we're evaluating for cellulitis, usually where we're going to be looking is in the subcutaneous tissue, as highlighted there. In the IV drug abuse population, or in cases where there could be penetrating trauma, we can see signs of infection into the deeper spaces, but if this is an atraumatic infection, it's likely that the money is going to be in that subcutaneous tissue. Now let's take a look at a cellulitis. When evaluating for cellulitis, the classic finding you'll appreciate is known as cobblestoning. Cobblestoning is exemplified in the ultrasound image here. Notice the islands of hyperechoic soft tissue surrounded by anechoic areas which represent fluid. This finding is indicative of inflammation and is synonymous with cellulitis. While non-infectious edema will appear similar, differentiating between these two entities can be made on physical exam as well as the brightness of the soft tissue islands. In acute infection, the soft tissue islands will appear brighter, while with edema, the islands will appear more dull. Another finding you'll appreciate on soft tissue ultrasound is an abscess. Compared to cobblestoning seen in cellulitis, an abscess will appear as a discrete hypoechoic fluid collection, as seen above. Sometimes you may also appreciate particles moving within the fluid, as seen here. This is known as a swirl sign and is actually a more specific sign of an abscess. One pitfall I often encounter is mistaking an abscess for a soft tissue infection. Often fluid in the abscess can become very hyperechoic and make it difficult to see. That's where the swirl sign comes into play again. Notice in this soft tissue ultrasound, if you didn't compress, you wouldn't appreciate that there's fluid there. However, the astute ultrasonographer does compression on this area and you notice fluid swirling around, confirming this is consistent with an abscess. Here's the second example. Again, the sonographer compresses down and you see fluid swirling around in a loculated pocket, confirming abscess, requiring incision and drainage. Two more pitfalls I want to just talk about real quickly when evaluating for soft tissue infection is two structures that you definitely want to avoid. Both of these are lymph nodes and blood vessels. Lymph nodes can often appear hypoechoic with a central hilum that appears bright, and this can easily be mistaken for an abscess. Blood vessels simultaneously can also appear well circumscribed and round, and if you don't use color Doppler, then you might mistakenly try to incise and drain a vein or an artery, and that wouldn't be good. So now let's move on to shoulder dislocation. As discussed earlier, notice how well the humeral head articulates with the glenoid. We can draw that normal alignment line straight across the glenoid and see that the glenoid and the humerus are at approximately the same level. Now with an anterior dislocation, there's displacement of the humeral head anteriorly, and when evaluating with ultrasound from a posterior approach, you'll notice that the humeral head is towards the base of the ultrasound image. So as we see here, the red outline shows the humeral head displaced anteriorly and the glenoid in its normal position. If we were to draw a line of alignment, you can see that now the glenoid and the humerus are no longer at the same level, and this would be consistent with the humeral head dislocation. Now once the shoulder is reduced, ultrasound can also be used to confirm realignment. This is a post-reduction of the same patient, and you can now notice that the humeral head is back in its normal position just next to the glenoid, and if we draw our alignment line again, we can now see that the two structures are back in line, confirming proper relocation. This can often be a technique that's used right after reduction is complete or while a patient is still sedated and there's question of whether the shoulder was successfully relocated. This can help prevent unnecessary resedation and help expedite dispositioning the patient. Now let's move on to evaluating for a tendon rupture. We're going to use the Achilles tendon because it's a great example and easy to visualize on ultrasound. So as we saw earlier, here's an example of a normal tendon. You can see the Achilles tendon in blue attaching to the surface of the calcaneus. And when you evaluate the overlying structure of the tendon, you'll notice the fibrillar appearance, and you'll see that it's smooth and homogeneous without any signs of disruption. Now when you're evaluating for a true tendon rupture, what you're looking for is both direct signs of seeing a tendon torn as well as indirect signs such as edema and swelling. In the image above, you can appreciate a full thickness tear of the Achilles tendon. Notice one piece of the Achilles tendon can be seen on the left and one piece of the Achilles tendon on the right. And in between, you're appreciating a hypoechoic collection of fluid that represents a hematoma. Now, as I mentioned earlier, you always want to be sure to evaluate for pathology in two orthogonal planes. So here we turn the probe 90 degrees and slide along the Achilles tendon, evaluating it in short axis. And as we move through, you can appreciate that as we move from the top of the tendon to the bottom, you see a complete loss of tendon integrity and just see surrounding edema and hematoma formation. While this is a very obvious tendon rupture, in partial tendon ruptures or partial tears, you might only appreciate surrounding edema or slight changes in the echotexture of the tendon, suggesting of a partial tear or partial injury to the tendon. And so you need to be aware when evaluating that if your exam is negative, it does not completely rule out a tendon injury, and I would use your clinical judgment to determine what the next course of management would be. So let's move on to our final assessment, and here we'll be talking about fracture. This is definitely one of my least common used ultrasound assessments. However, in cases where X-ray is reading the fracture as negative, I've often found ultrasound has identified fractures that were initially missed and changed management. So what we're looking at here is a long axis of a 7-year-old that had a mechanical fall onto the right hand, presenting with distal radius pain. So when evaluating for fracture, your eye should really be drawn to the cortex of the bone. In a normal, healthy bone, what you should see is a nice linear cortex without any disruptions. So here we ultrasound this patient's arm and we start on the metaphysis and we move down towards the diaphysis. And as we move down, notice that we appreciate a disruption in the cortex right in the middle of the screen. And this is consistent with the fracture. Not only will I often use the ultrasound to identify a fracture, but it can also be useful to help facilitate an improved hematoma block, as you can help get in between the two fragments of bone. But it can also be used post-reduction to confirm you have proper alignment of bones. So that concludes our introduction to soft tissue and MSK ultrasound, and I hope I've left you with some introductory skills and concepts to be able to practice your ultrasound in the emergency department starting tomorrow. So I just wanted to go over a few points. So as we've seen here, ultrasound can be very useful in evaluating for both soft tissue and musculoskeletal complaints. The most common complaints that it can be useful for include soft tissue infections, so differentiating between an abscess versus cellulitis, evaluating for foreign bodies, using ultrasound to assist with joint aspiration, evaluating for tendon injuries, fractures, and also being used to both diagnose and confirm post-reduction of a shoulder dislocation. Techniques that we discussed that you should focus on to ensure that you have a good musculoskeletal or soft tissue ultrasound exam is that you should always make sure the patient's appropriately positioned and comfortable and allowing you to perform a dynamic exam, ensuring that you're evaluating all structures in 2 planes, and this is important to avoid any errors and misdiagnosis. Also being sure to utilize the patient's normal side for comparison. If you appreciate anything abnormal, make sure to look on the other side and make sure this just isn't atypical anatomy. For small parts, it often can be difficult to apply the probe directly to the painful area, and so if you're evaluating parts such as a tendon of the hand or a fracture in the hand, it may be useful to use a water bath. And lastly, I want you just to be aware of pitfalls. While ultrasound is very useful in the emergency department for both soft tissue and musculoskeletal complaints, it's not the end-all be-all, and there's definitely issues you can get into when you're not familiar with them. Don't forget about anisotropy. If you notice that you're seeing a dark area in a tendon or muscle and you're suspicious for a possible injury, make sure to evaluate in 2 planes and also to make sure that your ultrasound beams are perpendicular to the structure of interest to avoid this error. Secondly, when evaluating for abscess, be sure to use color Doppler to ensure you're not going into a lymph node or blood vessel, as this could lead to significant complications. And lastly, as with any adjunct, ultrasound should be used to assist with your clinical decision making and should never trump your clinical suspicion for any specific diagnosis. Thank you all for listening, and I hope you go out and start scanning for MSK and soft tissue complaints on your very next shift.